Everybody, welcome back to Burst TV. Today I've got Misty Bridges. I'm excited to talk about this topic because I've been a dental hygienist clinically for about 20 years.
Mm-hmm.
And, it seems to me, correct me if I'm wrong, but it seems in the last 5 years, I've been hearing way more about orofacial myologists.
Yes.
And I even looked into it. I was like, this is life-changing, life-saving practices.
Mm-hmm.
I mean, this isn't just, oh, you've got crooked teeth, or oh, we have a frenum that's tight and we're going to correct some cosmetic things. These are life-changing things. And so once you open your eyes up to that, you start to see so many patients that need help. But it's been around for 45 years.
Mm-hmm. Yes.
So what in your that's insane to me. So the International Association of Orofacial Myology has been around for 45 years. Who's been at the helm of this, and why all of a sudden?
Well, what happened was in the 70s, it was taught in dental schools and in orthodontic residency, and then it got dismissed out of the curriculum. So a lot of the other countries accepted the philosophy behind form and function. And so we have countries like Australia, Japan, Brazil, a lot in Europe really ran with the idea of, let's look at the way the cosmetic features play into this, but let's look at how the muscle actually works with craniofacial growth and development. And so when it was taken out of our curriculums here, we went, we kind of made a shift in the way dentists and orthodontists view their treatment plans. And so now we've realized, there's been some things that maybe we've overlooked. And so now that we have more research, because that was the thing, everybody wants to know about research. Well, there's no research to prove this or that. Well, the other countries have been doing some of the research. So what we have basically is from them, but now we're catching up. And we have really great providers here that are coming up with really good research. So we'll be able to take that to not only the dental community, but the medical community as well, especially our pediatricians and even our ENTs and allergists, because we need to be working as a team. So that's how I like to explain it to people, because like in my state, when I first started in 2009, I was the third or fourth certified myofunctional therapist in the whole state of Texas. So
that's incredible.
I mean, that was pretty far and few between. And now I'm probably one of 12, I think we have. So
yeah. And I'm in that majority of people that looked into it, was very interested. I'm in Florida.
Mm-hmm.
Things are so restrictive, and I just didn't see a clear enough path,
right,
to make this happen for myself. Mm-hmm. And then things shifted around, and I did a whole 180 to something completely different.
Mm-hmm.
Are you working clinically still as a hygienist?
Yes, part-time.
Okay. So can you technically screen for patients that might need your help as a therapist? Okay.
Absolutely. So as a hygienist, every patient that we see, I always tell the dentist or the hygienist, when you're doing your oral exam, especially your cancer screening, you're looking at the same tissues, you're looking at the oropharynx, you're palpating, you're looking at everything. Just add another lens to what you're looking at. So yes, so we have a protocol. Actually, the IAOM submitted 2 years ago, I believe, with the ADA, a screening protocol. So you can go through, the dentist can or the hygienist can, and say, you know what, I see some things here that may signify, that you need to have further investigation. Let's look at your medical history, those patients that are snoring and bruxing and have reflux and TMJ disorder, and let's start putting the puzzle together. So everybody can screen. It doesn't mean everybody has to be an orofacial myologist, but you can screen and then refer as needed.
How long did your training take to go from hygienist to a therapist?
Well, that's a loaded
I know it was a little while
question.
ago, so they didn't have as
Yes,
many options.
right. So my initial class was, back then it was 32 hours, and it took me probably 2 years because I worked through, that was just the beginning. So I started out, I needed patients, so I had to work through a certain criteria of the amount of patients and complete patients to be certified. So it took almost 2 years because not only do you have the on-site examination, then you have your written exam, which you pass first, and then you have your on-site. So it's basically like we did with hygiene, going to boards.
Yeah.
Mm-hmm.
Yeah. So you put a little more time in. Now they've got, I've seen multiple weekend crash courses
Mm-hmm.
in addition to the certifications, the actual exams. So it just seems like there's a lot more options now.
Well,
A little more.
you have to have at least 2 patients that have been completed. So that's going to take you months.
Yeah.
So
Okay.
when you first start, you're just at the beginning and understanding, because it's a little overwhelming. You have so much information thrown at you that you kind of have to sit back and say, okay, how do I do this now? Let's
Right.
break it off in little pieces, and then form your plan and make your exercises and make your treatment plan the way you want it and customize it to your needs and your patient's needs. But it to be certified with the IAOM, it's going to take, I would say you probably couldn't do it within 6 months unless you have been practicing myofunctional therapy for a long time and you have that patient load that you can say, okay, I have these 2 patients to show that have completed the program. And so
And do
just
you find
starting
that
out.
that most, yeah, do you find that most hygienists look to their own patient base in a dental
Probably
office
so,
for their,
starting out,
yeah,
yes. So I separate my practice from my dental office. I do get a lot of patients from my dental office because my dentist is very good at saying, hey, you need to go see Misty for this. But she doesn't do that here. I don't do that in the dental office, so I have a separate office. So when I separate myself from the dental office, then I have referral base from other general dentists and other providers.
right.
But starting out, yes.
And I can imagine that would be quite, if someone wanted to transfer over into this career path full time.
Mm-hmm.
I can't imagine how long that would take to build a reputation for yourself, get that patient base, make this an interdisciplinary approach, and be able to get referrals from people in your community. So how does that process happen? I mean, are you I would imagine you've got to get business licenses. There's so many questions. How does the billing work?
Yeah.
Is there kind of a step-by-step, like what would be the reference that someone would go to?
Well, I remember starting out, I went around to the orthodontist first. And I remember one orthodontist saying, I'm not going to send any patient to you until you're certified.
Yeah.
And I thought, okay, I understand that and I respect that, but I need to start somewhere.
Right.
And then I thought, okay, let's reapproach this. I said, why don't you give me your hardest patient, those patients that you can't close their bite, and let's look and see what's going on. And then so I would have patients that would come to me maybe from the general dental office, and I would work with them and I would finish, and then I would send that case report to the orthodontist, and they would be like, oh, okay, there is something to
Oh,
that.
there's something to this. Like,
Right.
okay, you got my
And
attention.
yes, so I was able to build my practice, via the other avenues that the patients were coming to me. And because there again, the orthodontist, they haven't had the research to go on, and that's, their standard is they want to know if it really works. And now they can see the proof is in the case studies.
Yeah,
So
yeah. And I've been really impressed. There's an orthodontist in my area. One lecture that really caught my attention. He's the only orthodontist that I've ever heard talk about screening for airway issues. And he's like, I'd love to just do ortho on everybody, but certain circumstances, I'm like, no, you need to go to your ENT. Like, I don't want to just move these teeth around. That's irresponsible to me. So it's amazing. I love the fact that times are changing. Thank goodness. We're all working together, different caregivers, from the ortho to the medical, to pediatricians. So we're on a good path here. What you're seeing patients of all ages. What's the best way to get the message out to parents to look for issues where they might find your services helpful?
Well, I have a network thankfully, of providers in my area that I work with. I have a craniosacral therapist, I have a massage therapist, I have midwives, nurse practitioners, that when they see their patients, they say, you know what, I think there may be an issue here. The IBCLCs will say, you know what, we see this early. We think your baby is having a latch problem because of a tongue tie. Now, I'm not working with the babies. I'm only identifying soft tissue structures and then referring them to the appropriate professionals. But having a network of people with you helps. But I would say a lot of times I will start with the schools, and I will talk to the teachers, because they see the children that are thumb sucking or mouth breathing. And then I go to the pediatricians and I tell them the same thing. Look, these kids that you see that have upper respiratory infections all the time, allergies, that constantly have their mouth open, let's look at another reason why they may be in your office a lot. And then networking with moms in the MOPS groups on Facebook and different avenues. But it really spreads like wildfire when you get moms talking to moms.
Right. Yeah.
So, and then they tell their dentist, and then we can do lunch and learns at the dental office. And
so we talked about the kids a little bit. As far as adults, is there a time where you can't be helpful, or a lot of these conditions, the therapy is going to be beneficial to them?
Absolutely, because if you think about how many years they've been compensating, so they have multiple issues. And a lot of times it's those patients that you see in the dental office that come in every 6 months. Well, my splint's not working, my knot guard's not working. Well, we know that's not correcting the underlying problem. It can sometimes mask, although it does help, but we need to recreate that neuromuscular pattern. And so a lot of times the adults, they're in a lot of pain, upper shoulders, head and neck. And of course, I'm not treating the temporal mandibular joint itself, just the muscle dysfunction, and trying to get them in a neutral oral position and breathing correctly nasally. So yes, I see a lot of adults, and I've had adults that have benefited tremendously just from not doing anything surgically, not necessarily sending them off for a tongue tie release, but just correcting their oral postures and getting them sleeping better as well. Yeah. But you mentioned billing a second ago, and I didn't answer that. So that could be a hang up, because I don't accept insurance, because I can't bill. It's all private pay. So that is another issue that we differ a little bit, obviously a lot, from speech pathologists, because they will bill. And so, that may be an obstacle if you, if you are, I shouldn't say competing, but if there's somebody down the street that is accepting the insurance, and your parent says, well, I really want to come to you, but I'd rather bill my insurance.
Right. Yeah. I'll be honest. I mean, that was something that I looked at was technically you can't bill to the insurance companies, which I think is silly, but I mean, that's all legislation and money and red tape and stuff that, in a short period of time, we don't have control over.
And even if we could, I don't I don't really
I
want to.
probably wouldn't want to deal with that anyway.
That's right. We've experienced enough of that in the dental office, right?
Right,
So,
right. The write-offs and the headaches and trying to chase people down for payments and stuff like that.
yeah.
It just, it takes away from your desire and the joy
Mhm.
that comes from being the caregiver that you are. So I'm with you on that. I just
Mhm.
wouldn't want to deal with it. Listen, I just want to thank you, Misty, for coming on and chatting with me a little bit. Like I said, we could talk about this for days, but
Mhm.
I'm here with you to help implore for any um, caregiver that's in a clinical setting where you are noticing lisps, you're noticing snoring issues, you're noticing people are agitated, not sleeping. I mean, that medical history is
Yes.
full of so much golden nuggets, and you have the opportunity of investigating further and helping save people's lives, literally save people's lives. Yeah, so Misty, if any, would you mind people reaching out to you if they have questions and they want to get a little more insight?
Absolutely. I'd be
What's the
happy to
best way
talk to them.
to find you?
My office phone number is 318-595-1216. So you can leave me a message or text me. And East Texas Orofacial Myology. You can find me on Facebook. My website, I'm still in the process of keeping that updated. That's another thing. It's like I need multiple I need multiple hands, and I just can't get it all done,
It's a
but
lot. I know
it's
it's
a
a
work in
lot.
progress. So yes, you can find me on social media too.
Awesome. Thank you so much for coming. And
Oh,
I
you're
appreciate your time. And I'm excited to see what the future holds.
Yes, thank you for having me and spreading the word.
You're welcome. All right,
Okay.
guys, we'll see you next time. If you have any questions for Misty, you've got her digits. Let us know if you're screening for these types of issues, and hopefully Misty can come back on and we can talk a little bit more about what she actually does for these patients, that process. Thanks,
Okay,
Misty.
very good. Thank you. Bye.